Life goes on. The psychological processes of death, dying, and grieving. What do you know about the psychological aspects behind death, dying, and grieving? Well, first off, I'm going to start off with some questions that are going to be answered later in my presentation to get you a more better understanding of my topic. So, what is the death system? How does culture play a role in death? How do you choose life or death of another individual? What type of healthcare should be chosen for a death individual? How does death occur, and how do you face your own death, and how do you deal with the death of another person in your life? The death system, coined by Robert Katzenbaum. So there are different things that have to do with death. So for example, there's many different things that are associated with death, such as people, places, times, objects, and symbols. So first we have people, which are associated with death, obviously, because we all die at some point, and we all deal with people that we know dying. Next is places. Places that have to deal with death, obviously hospitals, funeral homes, cemeteries, battlefields. Next is times. Times also like an occasion that has to deal with death. For example, like Memorial Day, remembering the dead. We also have objects that have to deal with death. Usually these objects are associated with culture, such as caskets, or wearing black clothing to a funeral, armbands. And lastly, we have symbols that are associated with death. Usually that has to do with religion. For example, crosses or skulls. So what is death exactly? What is the actual definition of death? Well, death is the end of all biological processes. For example, it's the end of breathing, no more breathing, you have no more blood pressure, and your body is in the stage of rigor mortis. Also, when you're dead, you have become brain dead, which is when all electrical activity of the brain is eliminated, and that's when a patient will have a flat EEG, and the EEG is the machine that records the brain activity. But, for example, an individual who has higher brain portions may have died and can still be breathing and have a heartbeat because that is controlled by the lower brain portion. So the higher part of your brain can still be working, and the lower part can be still working and you'll still be alive. But if the higher brain part has died and the lower part is still working, you'll also still be alive. But brain dead means that both your higher and your lower parts of your brain and all their functions have died. So life or death decisions. First, I'm going to talk about patients who are unable to respond. So for example, what happens in a life or death situation with patients who are unable to respond? For example, they have long-term illness, they're in a coma, they're unconscious. So what usually happens is that an individual will create what is known as the living will before they die, when they're in the right state of mind, so they can decide what decisions they want to make about their life if they're in a life or death situation. So this is created when an individual can think clearly about their decisions. So an individual will express what medical procedures they would want done to sustain their life in critical situations. So not only does this occur in the will, but a patient or people in your lives you should trust someone to be able to tell them your exact decisions, what you want, so other people can understand as well. And the will also incorporates your patient's values and preferences, what that actual individual wants. Next, we have what is known as euthanasia, which is the painlessly ending someone's life. So a patient's life can be ended who is suffering from an incurable illness or a severe disability. There's two types. There's passive, which is withdrawing from medication or life-sustaining device. So the patient is taken off of their respirator or their heart-lung machine and they peacefully die. There's also active, which is an individual is induced. So they are pretty much injected with a medication, a lethal dose of a drug, which will kill them. So how do we care for the dying individual? Like, what do care providers have to do? What do loved ones have to do? That's what I'm going to talk about next. So when we think of dying in America, a lot of adjectives that describe it are lonely, prolonged, and painful. What happens for individuals in the dying stage is that doctors can prescribe them painkillers to reduce their symptoms and help relieve some of the pain they're having in their final stages. One of the problems we have lately in America is that research actually shows that doctors don't give patients enough information about how long they're going to live and how effective their treatment will be, and like how long the treatment may work for them, how much longer they can live with treatment. And next I'm going to talk about care providers. So care providers, their main goal is to allow the patient to experience a good death as much as possible, help them to go peacefully, help them to end their life in a positive way. So one of the healthcare programs that we have now that's pretty popular is known as hospice, which is a healthcare program which focuses on making the patients comfortable and free from like anxiety and pain at the end of their life, like ending their life in the best way. So part of a hospice is what is known as palliative care. This care focuses on relieving symptoms such as like pain and anxiety. And 90% of the hospice care is provided in patients' homes to make them feel even more comfortable. And studies have revealed that individuals who experience, so like say like you experience the death of someone and this experience happened in a hospice, people are able to get over the death of a loved one more calmly and easily when they go through the process through a hospice. So overall, really, what a care provider wants to do is reduce and relieve a patient's symptoms. Individuals act as individuals who can make it as comfortable as possible for the patient, show an interest in the patient and their family, and just help them be able to cope with the family, help the family to understand how to cope with the death of their loved one once they pass. So views and attitudes on death. So different ages and different groups understand death in different ways. So for example, the children and adolescent side. Infants obviously do not understand the full concept of death. They can become attached to their caregiver and understand like separation, anxiety from their caregiver, but they don't fully understand what death is. At ages 3 to 5, they still don't really understand what the concept of death means, but they think that dead people can be brought back to life. They don't fully understand that once you're dead, you're dead. And they also like to blame themselves for the death. They think, oh, like maybe like my mom died because I didn't do this right or I didn't do that right. Around ages 6 to 9, they understand that death exists, and when a person dies, like they're not going to come back to life. But some of them think that only death can happen to some people and not all. But by ages 9 and older, they can fully recognize the full reality of death. Adults obviously have the most full understanding of death. They are aware of aging. Middle adulthood, they start to actually think about how much time they might have left in their own life. And they fear death more than young people. They start to fear their own death. Then older adults, they're the ones that, once the elderly, they talk the most about death, and they examine their real meaning of life. And older alone men actually have the highest suicide rate. Communication with a dying person. So how do you communicate with a dying person? So psychologists state that the best is to inform the dying individuals about how they're dying, as well as the significant others in their life. They want to make sure that they understand that they are going to die and what their loving individuals should do because of it. When an individual is aware of their death, they can make decisions about their own death, and they can know what they should. They can tell like others what they want after they're gone. So like some of these examples are like, if they know that they're gonna die, they can complete their own plans and like projects. Like they have any last minute things they want to do with their life or whatever, they can do that. They can also make arrangements for their own funeral and burial, how they want it to be. They can converse with the people who had meaning in their life, so they can spend time with the people and family that meant most to them before they go. And they also can be more understanding medically, like what is happening, like why the doctors are doing what they are doing, and understand, like let the medical staff know what they want for their life as it goes through the last stages of death. Grieving is when losing a significant other. So there's many different things that can be associated with grieving. You have emotional numbness, you have disbelief, separation anxiety, you feel lonely, and this obviously occurs right after the death of a loved one. The more significant the loss, the more intense the grief. So 6 months after the death of a significant other, only 10 to 20% of individuals still feel like they have difficulty moving on in their life, and they still feel really depressed about it. And this can be categorized as prolonged grief. And the prolonged grief is enduring despair and is unresolved for an extended period of time. So they keep grieving longer than most individuals. And the number one most grieving incident or stressful experience a person may experience in their life is the death of their own spouse. So individuals grieving may experience many different things. They experience rapid changes in their emotions. They detect personal weaknesses and limitations of their own. They create new patterns of behavior, and they learn to form new friendships and relationships because of it. There are 5 stages of grief, according to Kubler-Ross. They are denial, anger, bargaining, depression, and acceptance. So obviously the first one, denial and isolation. An individual who just experienced the loss of someone goes into denial mode first. They don't believe that they're gone. They say no, they're still here. They can't accept that the person is gone and no longer here. Then they become very angry. They don't understand why this is happening, why this have to happen to someone they love. They don't understand. Then they go into bargaining. They'll do whatever it takes to get this person back. Like they say, if only I did this, maybe they would still be here. If only I did that, and they can't understand. Then they start to go through depression. They realize that the reality of the death, that the person that really meant something to them is gone, and there's nothing they can do about it. So they just become sad. They just want to be left alone on their own to grieve and to cry on their own. And then the final stage is the acceptance stage, where the individual finally accepts the reality that they died and that it was the end of their struggle, and that's pretty much it. Now I'm going to show you a short video that is kind of just funny about that gives an overview of the stages of death.
Now, a little death anxiety is normal. You can expect to go through 5 stages. The first is denial. No way, because I'm not dying. Second is anger. Why, you little dude! After that comes fear. What's empty fear? What's empty fear? Bargaining. Doc, you gotta get me out of this. I'll make it worth your while. Finally, acceptance. Well, you all gotta go jump time. Mr. Simpson, your progress astounds me.
So that's just a quick video to explain those stages of grief that I just mentioned. So next I'm just going to end by telling you how this applies to nursing specifically, which is my major. So obviously nurses are going to deal with patients who can die, who are going to be in the dying stage or who might die at any moment. They must know how to care for dying patients, and they must know how to provide care for them. They must understand the signs and symptoms of death of their patients, and they must understand what to do in a life and death situation. They must also understand how to provide hospice and palliative care, which we talked about before, and they must understand the ethical and legal issues and decisions regarding death. So nurses obviously apply to this topic very well. They also have to know how to interact with families going through death and with the visitors and the patients overall. And last, I'm going to talk about how this applies to our Christian faith. So first, I'm just going to start off with a Bible verse that is Revelation 14:13, which states, "And I hear a voice from heaven crying out, saying, write this: Blessed are the dead who died in the Lord from now on." And also the quote, "When the time comes for you to die, you need to not be afraid, because death cannot separate you from God's love." Charles Byrne. So just talking about how it applies to faith, Christians and the Christian faith, we don't have to be afraid to die, because when we die, we get to be in heaven with God. So there's nothing for us to fear, and death is almost a good thing in the end, because we get to be away from all the pain and all the anxiety, and we get to be with our Father in heaven. So people going through death a lot think about their afterlife, and they think about what's going to happen to them. So religion is a prime source of strength for people dealing with death. And death allows an individual to no longer be separated from God, because we're here on earth and God is there in heaven, and when we die, that separation is broken and we get to be with Him in heaven. So believers can face death without fear. They can enter the Lord's presence at death, and they can be with God for eternity now that they are dead. So this wraps up my presentation, and I hope you can now understand more the psychological processes of death, dying, and grieving.